Thanks very much, Scott. We'd like to acknowledge the Thurabal people, the traditional owners of the land on which we meet, and Marichi for her wonderful welcome to country this morning. What an inspiration. I'd also like to acknowledge the Kalkadoon people on whose land we live and work in Mount Isa. And the funders for this project is to have the chance to test an idea and give it a run in the paddock is just fabulous. And so for HWA and the Regional Clinical Training Network and Queensland Government, we are eternally grateful. So our project will give you the official, what we set out what we'd like to do. And we really wanted to try a different way of building mental health placements. The priority areas that came up really in this funding round really suited us. We're remote, we're rural. We'll show you why in a moment. We have a real challenge in supporting our mental health services, and as a University Department of Rural Health, a challenge in facilitating sufficient clinical placements to really build a future workforce. And so by trying to tackle this differently was something we wanted to do. So, and the reason we wanted to do this is that our services are very, very fragile. This would not be new to anyone else who works in a remote area. Our services are very constrained. They're not unwilling participants at all, but they are very fragile in that they've got small numbers and huge workloads and large distances, and so their ability to take on students is dramatically, they're very constrained. And they also have quite a few relatively inexperienced practitioners, and this is the wicked problem of rural and remote health, for those of you who've been in the game for a long time understand. And just as we heard before, if we keep doing what we've always been doing, we'll always end up where we are now.
And let's get realistic. Mount Isa, for those of you who've been there, it's not the prettiest place in the world, so it is very hard to recruit and retain. Yeah,
only our mother could love us. So the context, so our region that our University Department of Rural Health covers is a third of Queensland. Realistically, we don't do a great job of that, but we're very enthusiastic. We have a much stronger presence in the northwest than the central west. Certainly the health need, when you look at the health differentials or disadvantage, the greatest disadvantage is in the northwest. We're around about building capacity, and certainly we would all agree that we're lacking capacity. We certainly have the aspiration. We've got some experience in innovation, and we wanted to try and draw across from a previous experience into this context. And so let's talk a little bit about the model, the things that we put into the model. So our service learning model is one where we want to be able to do a little like we heard before on the spinal injury, where if you've just got an individual practitioner supervising a student to provide a service with individual clients, then you can only see so many in a day. If you reorientate that to supervise the students who are suitably selected in a context that is underserved or where the service doesn't exist, you can reorientate what you do. And we've been testing this in the neuro rehab area for a little while. We're not completely there yet, but we're really, really excited by what we've achieved. And so we wanted to draw that lesson across to see what could we do here. So we really started out with big aspirations, lots of confidence, and of course we got put neatly back in our place by all of the unexpected barriers that we expect to come up in remote areas, that we didn't know what they'd be, but we knew they would come. We identified some things that we really needed to do. So first of all, we wanted to support the mental health services, which are provided by a range of providers. There's the Queensland Health Services, there's some not-for-profit community services like Centacare and Nuix. There is the Medicare Local, who provide services largely out of Mount Isa in the region, but also some in Mount Isa, and RFDS that provide them out of Mount Isa. There's Gidgee, our Aboriginal Medical Service, that doesn't specifically have mental health services, but clearly have to provide a lot of healthcare to people with mental health problems. So we looked at how do we upskill the people who are there, and the leaders of these services had said to us, wouldn't it be great if only we could. And we went, okay, tell us what the if only is. We've got this once-in-a-lifetime opportunity. What's the if only? So if we could train some of our staff up and provide them with the supervision and support to be able to reorientate some of the way they practice. So we don't have any group work at all in Mount Isa. And so for those of you who practice in the city, you go, what? How come? Well, we just don't. We don't actually have enough people who can stop for long enough, do the training and then reorientate what they do. And so that requires leadership. And so with that support, we've brought in mindfulness training. There was other areas they identified that they wanted to skill their workforce up. And when we say their workforce, we're talking about 5, 6, 7 people across the services, maybe 8 or 9. We're not big numbers. We recognised that supervision was a major rate limit, particularly with psychology, because they're so anal, with their requirements, not the psychologists themselves. And so they really limit themselves in being able to build a workforce for particularly remote areas. But also we've noticed in our rural areas there's been a really negative impact of some of the more recent developments. And so we built into this, it's really important for us to identify people who might be close to being eligible to be supervisors, and then let's bring the training to them so we can, in one hit, build our capacity. So there were our things. The other feature was then we wanted to recruit students in a multidisciplinary group, reorientate our student programs and then match them up with the supervisors. And we're going to do all of that in less than a year because we know we can. Well, even we learnt some lessons about ourselves. So I'm not going to labour this point, but what we really wanted to do was support the reorientation of services and the introduction of new services that involve the upskilled local health professionals that were able to support each other across services in a formal and informal way. So some of that working in the spaces or the gaps we heard so wonderfully described this morning. And in a very concrete way, say with particularly our psychological services, have a solid base of anybody who was eligible, upskilled to be able to supervise, and then introduce some new mental health services from within the current garden bed of offerings so that we can then also plumb students into a wider range of activities which would better prepare them for the context of rural and remote practice. This stuff takes quite a bit of time, and so what we recognised we needed to have a project manager, and so that's been Kay, who's just been fabulous, and she's going to talk a little bit about some of our achievements. We wanted to employ a supervising psychologist, and this turned out to be probably our major barrier. To have someone who's sufficiently senior enough and experienced enough and understanding the context of remote health. And I know there's got to be at least 7 of them out there in the country, and I think we spoke to them all, but nearly all of these people are in private practice, and to be able to take them offline, we couldn't compete with their income requirements to be able to, come and live with us in Mount Isa for a couple of months and we'll, pay you nicely, but clearly not what you earn. And so we had to rethink that, and we were able to overcome that, but it took us months and months and months. And that was a hurdle we didn't expect to encounter. From my previous experience, there's been sort of strong levels of indication where people really want to get involved in Aboriginal health and remote health, but when the rubber hits the road and the reality comes down to the dollar, in fact, there's a major barrier there, so we do have to think that differently. The specific workforce training we provided was the mindfulness-based training, which we've done, DBT, which is happening in the next couple of weeks, and the STAP training, which is the last cab off the rank, which is also happening in a couple of weeks. So we'll skip past the deliverable outcomes, and you can talk to sort of what we set ourselves as our own KPIs, is to, what we wanted to guide us to make sure that in this really short time frame that we could get the best out of the project. So perhaps, Kay, if you walk us through. Okay. You swap over so you can be heard. Sure? Yeah, of course.
I think I've got a big enough voice, really. Okay, so I'll just skip through the first couple of dot points and go on to our evaluation. We have evaluated parts of the students, and we still are in the process of evaluating the training side of the project. Student placement, I felt, was really, really successful this year. Low in numbers, but I still think that we had 3 social work students on placement. That's a bit scary, isn't it? For the whole of the year, we've only had 3 social work students. They were placed with Centacare and Northwest Hospital Health Service. One of those social work has secured full-time employment as a part of that. So I think that's a really great hit for us. The supervisor training.
So just to say, we've had 9 psychology students, some of those undergrad, and we've had nurses doing mental health placements. So we aimed to get 14 students, and we came in on 12.
12, yeah. Better next year, eh? Yeah. So on top of that, with the STAP training, we have 1 clinical psychologist who is STAP trained for the whole region. As a part of the STAP training that we will be delivering in Mount Isa, we will end up with 12. So we think that's really, really great. So that's on top of that. The mindfulness-based training, we had 8 participants register for that, and as an outcome of that mindfulness-based training, we had health professionals on the ground level create partnerships, and out of that, what they've done is they've walked away with, they've actually now are co-facilitating mindfulness training on themselves as a group, but bringing in their staff. So we've got Medicare local staff attending, we've got Centacare staff, and we've got our own micro staff, and so they're practicing on each other. And then because they deliver into the rural areas, when one is out of town, Centacare is going to pick up and deliver it from that week. So I think it's been very, very successful. So
just quickly, some of the lessons we've learned. So there's a couple of things we set ourselves out to do, and we set up so we wanted a high-level reference group because we expected, just from our past experience, there'd be unexpected things. But what we didn't realise was just how long it was going to take, despite our collective experience in remote health being something excess of about 45 years, maybe like 50 years. The short time frame in having a year project for as we've heard described, the funding comes in, to go through the processes of recruiting students to come to our areas, to put in a different configuration requires much longer than 6 to 9 months lead time to be able to secure them. And so we've now got students secured for next year, but we aren't able to apply the financial support we're going to provide them for next year, but we've secured the students, we think, and we'll leverage all of our infrastructure and support from the UDRH to make that happen. So I think that an important lesson out of all of this is around the short time frame for rural and remote projects, and I note that that's a priority area next time round. I've talked about the psych. We started conversations which exposed some of the either myths or not myths around why services can't take students. And one of them is in funding contracts that services, particularly mental health services, need to be provided by qualified health professionals in some funding contracts, and that's interpreted as therefore a student can't provide. And so there's something tangible we can fix, and there's something tangible that we would like to fix, but it's going to take a lot more to fix around the supervision requirements that the Australian Psychological Society have around their tolerance of remote supervision as being suitable to be able to provide quality supervision. We know that in other disciplines we've been able to provide this evidence base. So in relation of sustainability, we've now got a skilled up, better skilled and built capacity in our mental health services. They are now starting to run groups. They've done their practice runs on volunteers. They're starting to run groups. They are starting now to work informally, like we heard before, in being able to configure their work. They are much more interested in including students in this, and that's a major barrier. And the fact that the services have been almost brought to their knees by the concrete cancer in the major block of the hospital, which has been an enormous distraction for the last year, means that finding other ways to deliver services and banding together has both worked against us but also worked for us. So in finding those other ways. So thank you very much.
And this is just a testimonial from a psychologist in private practice who's actually taking 2 days off work to do the STAP training. So and I thought that was just really great.
Yeah.